to everyone to this 2024 National Webinar on Pediatric Infectious Diseases on the eve of Children's Day. I'm Dr. Akash Agarwal, your host for tonight. We have an enriching program with a distinguished lineup of experts who will share their insights into the latest developments in pediatric dermatology. To start off, it's my privilege to invite none other than Dr. Jacob Thomas, sir, President of the Indian Society of Pediatric Dermatology. Sir has been a pioneering figure in pediatric dermatology with decades of experience, and his leadership and dedication to patient care continue to inspire us. Sir, please.
Thank you, Dr. Akash. Good evening, everybody, and happy Children's Day to all of you. We've always been children and will continue to be children at all times of our life. It's wonderful for me to be here in my role as the President of the Indian Society of Pediatric Dermatology to welcome you all. I'm here only to welcome you. All the other technical proceedings will be done by the two people who are at the helm of affairs, namely Dr. Rahul Mahajan and Dr. Ram Gulati. Now, these two people have been doing exceptional good work, so I welcome the two of you also very much. And of course, our very good senior advisor, Dr. Sandeepan Dar, and all who are online now, those who are online, those who are wanting to be online, but for some unforeseen circumstances are offline, I welcome all of you. You will have a recorded version of this put on the website, and you can all enjoy this for posterity. Thank you very much once again. It's not vote of thanks, but still, it's only a welcome address, welcoming the speakers, Tharun Naran, and my very good friend, Arun Inamdar. I was in contact with him just a few days ago and got a very good, big compliment from Arun. Thank you, Arun, for those compliments, and all the other panelists, Dr. Darshini, Dr. Neetu, all of you, welcome to this wonderful meeting of pediatric infectious diseases. Let's make it very, very clear that it is pediatric cutaneous infectious diseases. We're not going to talk of general infectious diseases. Thank you very much for being here with us. And I pass the microphone on to Dr. Rahul Mahajan to set the meeting in order. Thank you very much.
So thank you, sir. So good evening, everyone. And as sir said, happy Children's Day to all. And on behalf of the Indian Society of Pediatric Dermatology and the ISPD Academy, I'm delighted to welcome you all on this Children's Day to this national webinar on pediatric infectious disease of the skin. We all know when ISPD was founded, that was in 1996. Yet, this initiative of ISPD Academy is a novel first step, so as to say, to further strengthen the academics and research in the field of pediatric dermatology at the national level by initiating various continued medical education programs like the today's webinar, which you can say is a first in the series of webinars that will be conducted every 3 months, every quarterly, and they will ultimately culminate in the national conference that will be held physically every year. Another responsibility of this ISPD Academy will be to formulate evidence-based guidelines on various pediatric dermatoses and to conduct various multicentric epidemiologic studies. And all these activities will be under the guidance of ISPD President Dr. Jacob Thomas, the past President and now the Chief Advisor of ISPD Dr. Sandeepan Thar, and with the full support of the Secretary General Dr. Maitri Panda. So, as the coordinator of ISPD Academy, I have the pleasure to introduce Dr. Ram Gulati also, who is the convener of ISPD Academy, along with the energetic team of Academy members comprising of a mixture of experienced and young pediatric dermatologists, some of who are a part of today's webinar also. So, just to name all the current members of ISPD Academy, I have the pleasure to introduce Dr. Abhijit Saha, Dr. Akash Agrawal, Dr. Arunima Ray, Dr. Darshini Satish Kumar, Dr. Neetu Bhari, both of whom are part of panelists in the current today's program. Dr. Suman Patra, Dr. Sahana Raju. I'm sure as the ISPD Academy works, more and more people will be associated with it and will be interested in both the research and academic activities of ISPD Academy. Coming to today's webinar, we all know that skin diseases are a major burden of, especially of the in the pediatric age group, they are a major burden, contributing almost one fourth of all the OPDs, both in the urban, rural areas, all settings, whether it is the teaching settings or in the private practice. And if you say the infectious diseases of the skin, again they are the major chunk, whether in you say it's the rural population or in the urban population. Most commonly, it is invariably the infestations, infections, bacterial, viral warts, molluscum. So all these things we have tried to incorporate in today's webinar, but we have tried to go much beyond it and leave no stone unturned and include all aspects of pediatric infectious diseases which may be less commonly seen, like the granulomatous disorders, including the various deep fungal infections, tuberculosis, and leprosy, and especially febrile conditions that may present with um, predominant skin manifestations. So, all in all, I welcome you again to this webinar and let the webinar begin. I give the mic back to Dr. Akash to start with the proceedings of the webinar. Thank you.
Thank you, sir. Thank you, Jacker, sir, and thank you, Rahul Majan, sir, for your welcome address. So, to begin our first session today, we welcome Dr. Tarun Narang, sir, who is an additional professor at PGI Chandigarh. With over 270 publications and presentations, Dr. Narang, sir, is a recognized authority in dermatological research, especially in the areas of leprosy, NTDs, psychodermatology, and psoriasis. He'll be speaking on the approach to infectious granulomatous disorders. Sir, please.
At the outset, I would like to thank Dr. Rahul for giving me this opportunity. And I'm also thankful to ISPD for giving me this opportunity. And today I'll be speaking on approach to infectious granulomatous disorders in children. And we all know what a granuloma is. Granuloma is a focal chronic inflammatory response to tissue injury, which is characterized by a collection of activated histiocytes, epithelioid cells, multinuclear giant cells that may or may not be rimmed by lymphocytes and may or may not show central necrosis. Depending upon the triggers and the host's immune mechanism, granulomas can be of different types. They could be tuberculoid granulomas, they could be sarcoidal granulomas, foreign body, necrobiotic granulomas, and the histopathology of each of these is characteristic. So today we'll be talking about pediatric infectious granulomatous diseases, and there are certain unique considerations in childhood uh, which are different from adults, like the immature immune system in children. Uh, that has an impact on granuloma formation, and the granuloma formation may not be complete or it may be atypical. Then these children have exposure risks which are distinct as compared to adults, and chronic granulomatous diseases like leprosy or tuberculosis for that matter, they have developmental implications because they have a potential on growth impact rather, and psychosocial effects as well because of the disabilities or the deformities that are caused by these skin diseases. The common causes are mycobacterial infections, which include tuberculosis, leprosy, non-tuberculous mycobacteria. Fungal infections are increasing. We are seeing more and more of sporotrichosis, chromoblastomycosis, although not that common, but we do get to see aspergillosis and few hypomycosis a lot, especially in immunocompromised population. Parasitic infections like leishmaniasis and post-Kala-Azar dermal leishmaniasis. Then certain bacterial infections like cat scratch disease and nocardiosis have also been reported in children. Uh, the morphology of all these chronic infectious diseases is not very different, and many a times it is difficult to pinpoint the etiology based on morphology, as you can see here. You have hypopigmented plaques, which can be seen in both leprosy and post-Kala-Azar dermal leishmaniasis, mycetoma, then filariasis, then lesions on the nose, which are seen in cutaneous leishmaniasis, but fungal infections as well, piohyphomycosis, chromoblastomycosis, mycetoma, Burulli's ulcer, a big Burulli's ulcer or a child. So we don't see that much of Burulli's ulcer in India, although there are a few case reports which have described, but they were not able to isolate the organism. But we do have atypical mycobacterial infections, and the thing is that these are not that commonly diagnosed. We are missing a diagnosis of atypical mycobacterial or non-tuberculous mycobacterial infection. As I said, leprosy is relatively easy to diagnose, hypopigmented or erythematous plaque with loss of sensation, and if you do a slit skin smear, it is positive in lepromatous pole and it may be negative in tuberculoid pole. So if you have a patient like this with multiple lesions, although eliciting sensory loss in children is a tough task, but if you are able to show that you should able to show thickened nerves, then the diagnosis of leprosy is not a problem. But if you have cases like this, cases who have been diagnosed as leprosy, treated with MDT, and the lesions are persisting or increasing, then you have to think of alternative diagnosis. Like this is a case of post-Kala-Azar dermal leishmaniasis. And the characteristic lesions, if you see, are in the muzzle area of the face. And these are the type of nodules that you see. You see polymorphous lesions, you see hypopigmented lesions, you see nodules here, big nodules on the ear as well. You do a slit skin smear, it won't show M. leprae, it will show LD bodies. So that is where the investigations come into play. Coming to our first case, which is a 15-year-old male from Himachal Pradesh with a 4-year history of progressive ulcerated plaques on the left lower limb. These lesions, they started from the sole, and although the patient doesn't give any history of prior trauma, but sometimes the trauma goes unnoticed. And eventually, over a period of 4 years, the lesions kept on increasing. He had partial response with antibiotics, and sometimes the lesions resolved on their own. But the progression continued, and this was the picture when he came to us. He had lesions on the left leg, and you can see the lesions started as this plaque, which is present on the sole of the foot. Then they progressed in a sporotrichoid pattern all along the left lower limb, and the lesion on the thigh is a plaque which has scaling, hyperpigmented border. There is some scarring here, scarring along these lesions which have spontaneously resolved. He also had discrete inguinal lymph nodes. Although he didn't have any systemic abnormalities, no history of fever, chest pain or cough, or any weight loss, and no history of contact with a case of tuberculosis. So with these we kept the differential diagnosis. The factors which influenced the differential diagnosis were plaques with central ulceration and some which showed crusting and scaling also, atrophic scarring which was seen in some of the lesions, sporotrichoid pattern, chronicity of course, 4 years is a long duration for any acute infection to persist, then lymphadenopathy. So based on these, the lesions on the thigh looked more like lupus vulgaris, so we kept a possibility of cutaneous tuberculosis. Then some lesions on the lower limb, they looked like chromoblastomycosis or sporotrichosis, since the lesions were in a sporotrichoid pattern. Then atypical mycobacterial infections we get to see a lot, so we kept this possibility as well. And we also kept a possibility of chronic cutaneous leishmaniasis. So, a diagnostic approach in such a case is a detailed history, examination of the lesion morphology, site and distribution. History again is very important. Everything is not a spotter. At times, the history gives you clues. Because in this case, the patient was hailing from Himachal, where certain infections are more common as compared to the others. So we will see. We will, as we go through this talk, we will discuss the differentials pertinent to this case also. Then you do lab tests. There are side lab tests like skin smears or gram stain or a QH stain. Then histopathology, a biopsy is a must because the morphology in this case was not clear cut. Then you can do histopathology for histopath as well as special stains. Microbiology comes into picture, cultures, PCR. PCR is a very useful tool when we are talking about diagnosis in cases of chronic granulomatous infections. And imaging studies or additional studies. This case had the lesions on the leg. So X-ray can be done in case, especially if the lesions, if you find that the lesions are fixed to the underlying bone, or if there is any bone pain or joint pain, then these cases do require a X-ray of the extremity or MRI if you want, if you have facilities available. So as I was talking, that history is again very important, and the place of residence, because if you we'll be discussing all these possibilities, that is sporotrichosis, chromo, lupus vulgaris, and leishmaniasis. So sporotrichosis and chromo are more common in the South Himalayan belt and in northeastern states and parts of Karnataka as well, whereas lupus vulgaris is ubiquitous, it is everywhere. Leishmaniasis again, it's more common in Rajasthan, Himachal, and now we are seeing more cases of Jammu and Kashmir as well. History of trauma, thorn or a vegetative trauma goes more in favor of sporotrichosis or chromoblastomycosis. In case the patient has history of insect bite, which we rarely get, then you start thinking of leishmaniasis and history of spontaneous resolution. As we saw in our case, there were few lesions which had resolved spontaneously, but the disease kept on progressing. Even in lupus vulgaris, one of the margins would be healing with atrophic scarring, and the other side would be progressing. The history of signs and symptoms of TB also is also important. Similarly, family history of leprosy or TB in case you have a lesion of that type. Then history of recurrent infections involving multiple or different organ systems. This takes you towards the primary or secondary immunodeficiency disorders. This too has to be taken in such cases, especially those who are not responding adequately to the treatment. Examination, as I mentioned, sites are important. Porotrichosis and chromoblastomycosis are more common on extremities, which are prone to trauma. Lupus vulgaris lesions are more commonly reported on buttocks, thighs, and even face at times. Leishmaniasis is commonly seen in the head and neck area. Then presence of lymph nodes or absence of lymph nodes, the pattern of spread, sporotrichoid spread, then the morphology of the lesions, as I did discuss. If the patient has black dots and a verrucous surface, that goes more in favor of chromoblastomycosis. Lupus vulgaris would have scarring at one end and progressing or the advancing border at other end. Leishmaniasis would be scaly erythematous plaque with focal ulceration and crusting or scarring. We will see some of the images here. This is the case. This is a lesion of lupus vulgaris with scarring and then progression at the borders. Again, a disseminated or a big plaque of lupus vulgaris. This was a case who had received topical steroids and systemic steroids as a result of which he had many lesions like this. This is leishmaniasis on the neck, central ulceration, crusting leishmaniasis here on the lip in a child. And this is also a verrucous lesion, which may be diagnosed as chromoblastomycosis or TBBC, but it turned out to be a lesion of TBBC by histopathology. Then among the fungal infections, sporotrichosis and the characteristic verrucous appearance with black dots with the arrows shown here, or even here, this is chromo, and this is a case of few hypomycosis in a child who had renal transplant. This is a great masquerader. It can present like verrucous lesions, plaques, ulcers, or a cystic lesion. So coming back to our case, you see these are plaques with central ulceration and crusting, some scarring here, and this is something that took us towards lupus vulgaris, the scarring at one end and progressing. This is more like chromoblastomycosis. This again can be said to be chromoblastomycosis, but the sporotrichoid spread is there. So we do need help of our friends in microbiology and pathology to help us with this. Dermoscopy is an evolving tool and is helpful in certain cases, although there are no characteristic features which can be ascribed to any of these. Although people have shown that grains are are better visualized with dermoscopy, so you can take a smear from that. Then these are the side lab investigations, QH mount for the grains, or if you are suspecting sporotrichosis, a split skin smear from that can also show fungus. Montu test in cases where you are suspecting TB, slit skin smear for leprosy or PKDL, and even lupus vulgaris people have done this. Histopathology is very important. If we see there are certain characteristic features of each of these disorders. There is a mixed granulomatous reaction with neutrophils in cases of fungal infections, or you must say sometimes acute on chronic. And if you are lucky, you can find yeast or hyphae on PS stain. Lupus vulgaris would have a characteristic caseation necrosis with characteristic tuberculoid granulomas, and leishmaniasis again, there is a dense diffuse mixed inflammatory infiltrate. And the characteristic feature or something which kind of helps you narrow down the diagnosis towards leishmaniasis is presence of plasma cells. That helps. And then if you are able to demonstrate LD bodies, then you've got your diagnosis. These are histopathological pictures of subcutaneous fungal infection, chromoblastomycosis. This is an asteroid body. These are the copper penny bodies that we talk about in chromoblastomycosis. This is the characteristic histopathological picture, a scanner view and a high-powered view in case of lupus vulgaris, chronic cutaneous leishmaniasis with the arrows which are showing the LD bodies, and the Langerhans type of giant cells. So histopathology does help, but there are 25 to 30% of the cases where you are not able to make a diagnosis. So our case turned out to be chronic cutaneous leishmaniasis based on the histopathology and the presence of LD bodies, and even the PCR was positive. 1-2 test was negative, and local imaging showed no bone involvement. The patient was treated with amphotericin B as he failed to respond to fluconazole or itraconazole, and sodium stibogluconate and miltefosine are not available here. So second thing that helps is culture. Culture is very important. When you send a sample for histopathology, simultaneously you should also send samples for culture. Although it does take time and the positivity rates are quite low, but if you are able to demonstrate or grow an organism, that is the gold standard. So we have better culture media for tuberculosis, leishmaniasis, and even subcutaneous mycosis. You have to inform your microbiologist that these are the things you're suspecting so that they can accordingly use the appropriate culture medium and the stains as well. Emerging diagnostic techniques are PCR or next generation sequencing, which are very useful even with small bacterial load, which is mostly seen in most of our cases. It is very difficult to demonstrate organisms by culture or smear. So PCR does come to our rescue. Rapid antigen tests are being developed. So far, we don't have any test which is approved. Now, this is the second case, a young girl with this swelling on the face, which had been there for the last 5, 6 years. She has taken multiple treatments. She has been treated for fungal sinusitis, but there was no response. She had undergone FES as well. So this history and this evaluation is quite characteristic of rhino and mycosis. And we did a MRI of paranasal sinuses, which did show sinus involvement of hard palate, zygomatic bone as well. But what clinched the diagnosis was this nasal scraping. The site of biopsy again is very important. If you take a skin biopsy from a case of rhino and mycosis, you might not be able to demonstrate much of changes or and even the organism. But nasal scrapings from this case showed acute angle branching slender septate hyphae, which are not seen in rhino and mycosis, and these and fungal culture confirmed that this was aspergillus, which is quite an unusual presentation for aspergillus, and she was started on treatment. She received liposomal amphotericin B infusion for 14 days, followed by oral itraconazole. The thing with these infections, chronic granulomatous disorders, is they need prolonged therapy. And the response is quite satisfying. It really changed this girl's life. So, early diagnosis and the correct diagnosis so that you can initiate the correct treatment does help. Does help. Then we have newer modalities like multiplex polymerase, where you don't have to send separate PCRs. You have a multiplex polymerase depending upon the epidemiology. Like we had a study from PGI where they developed a multiplex PCR for MTB, leishmania, and pan fungal. And it did show good sensitivity and specificity in many of the cases where culture was not able to pick up the infection. So this is another case. What would your diagnosis be? You can say a sinus which is present on the mandible, which has been there for the last 6 months. An X-ray of the mandible showed this. And the thing that we should be looking here is this lucency around the root of the molar or the premolar. And this was a case of cutaneous odontogenic sinus. The case had been treated with a diagnosis of leishmaniasis, actinomycosis, but he was not responding. He was sent to the dentist. You can even see the caries in the tooth here. So a root canal treatment was done and this lesion dissolved. So many a times simple tests can help you reach a diagnosis. Then, as I did mention in the beginning, recurrent infections or recalcitrant infections always look for primary immunodeficiency or secondary immunodeficiency. We can't discuss that here. Maybe we'll have another webinar on this. We'll request Dr. Rahul for that. But there are multiple diagnostic challenges like non-specific symptoms, biopsies. It is difficult to take biopsies from children, false negative tests like in Montus or IGRAs. Then even the treatment is not that simple. We have limited pediatric drug formulations, which are not, we have capsules, we have tablets which children can't take. Clear dosing guidelines are not developed for many of these conditions, and side effects again, we require monitoring, we require blood tests, which is difficult to do in a child. And eventually, if the child is not treated, the growth and development is retarded. Multiple side effects, psychosocial effects, effects on family should also be taken into account whenever we are treating a case of granulomatosis skin infection. So, to summarize, history and examination are crucial. Not everything is a spotter. And a stepwise approach, which includes bedside investigations, routine tests like Montu or slit skin smear, histopathology, culture, and antifungal or antimicrobial susceptibility. Wherever you do culture, always ask for antimicrobial susceptibility because drug resistance is increasing in these disorders. We are seeing a lot of cases of drug resistance in leprosy, fungal infections, infections which respond to treatment earlier but eventually stop responding. So if the investigations are non-contributory, a therapeutic trial based on your gut feeling or what you feel is the right diagnosis can be done. That can also help, especially in cases of tuberculosis and even in leishmaniasis many a time. And we hopefully will get better investigations like a multiplex PCR, which can take care of the common pathogens. And eventually, the approach is multidisciplinary and family-centered approach, which is very important if we are managing these children. And these are my references. And thank you once again. Thank you, Dr. Rahul.
Thank you, sir, for your excellent talk on a challenging topic of pediatric granulomatous disorders. I'm sure all our participants have taken in a lot of points which will help them in a day-to-day clinical practice. Next up, we have none other than Dr. Arun Namdar, sir. Sir is Professor, Department of Dermatology at Sri B.M. Patil Medical College Hospital. Sir is also the Pro Vice Chancellor, BLDE University, Bijapur, Karnataka, India. Sir's illustrious career includes more than 300 publications and 12 books edited. Sir is Associate Editor in the BMJ Case Reports. Sir is also an Associate Editor in Clinical Case Reports under Willy Online. Sir has done his fellowship in WHO, Royal College of Physicians, and KSTA. Sir is a section editor in the Pediatric Dermatology Society newsletter, USA. Sir is also a mentor in the International Society of Pediatric Dermatology. Sir's areas of interest include pediatric dermatology and critical care in dermatology. So it's my pleasure to invite you on your talk today on approach to a infectious origin of a generalized rash. Sir, please.
Yeah. Good evening to all. This will stop other screen. Okay.
Yes, sir, I've done so.
1 minute. Yeah. Okay. Good evening to all and respected teacher, Professor Jaikar Thomas and Sandipanda, Rahul, and other friends. It was a wonderful talk by Tarun on infectious granulomas. My talk is approach to generalized rash of infection origin. The first step would be rule out drug as cause. So that has to be done whether it is in children or adult. In fact, in children, drug is a less common cause to be ruled out, but still the drug as a cause has to be ruled out. What is a rash? A rash is a visible lesion of the skin due to disease. The condition can be either primary skin disorder or a symptom of a systemic process. Well, an eczema is a skin rash that may be associated with mucous membrane eruption. We call it as enanthema, fever, or other symptoms. They may develop as a manifestation of an infectious disease or as an adverse reaction to the drugs. Exanthema may be a classical exanthemas commonly occurring in childhood or atypical for different morphology and causal agents. Among the atypical exanthemas with infectious etiology, we have viral, bacterial, parasitic, and helminthic infections, which are also implicated. Well, for any rash, we have to have the history, like onset of the rash, type of the lesion, what was the distribution, progression, general well-being of the children, infectious contacts. This is very important for various diseases, and drug history, which I already told you. Symptoms of the rash, what is its association, itch, pain, or burning, a travel history, and even contact with pet and other animals is also important. And also you should have a good physical examination of the entire skin surface to know the extent, type, distribution, and evolving lesions, and mucous membrane involvement like ulcerations or any lesions, conjunctiva for injection and episcleritis, and you have to examine scalp and hair for areas of inflammation, scaling, or hair loss, and you must examination any generalized rash, reticuloendothelial system, whether there is lymphadenopathy, whether there is hepatosplenomegaly, and most important in children is joints, or even in adults, for example, for that matter, joints for any associated arthritis. And the clinical correlation as far as pathology is concerned, like what is the expression? Macules, papules, petechiae are always due to dermal capillary endothelium, where there is damage to vessel, endothelial swelling, perivascular edema. So these are the various things. And in dermis, if involvement is dermis, you get papules, urticaria, purpura, and vesicles. And only papules, vesicles, and ulcer, only epidermis can also be involved with these presentations. So in a way, even the lesions also speak the pathology behind that. This is the idea why I wanted to show you this slide. Well, the common ones, what will be my talk? I will be showing you some of the infections which can rash, and I will show you some clinical pictures, what you should look for instead of going to case scenarios like what Tarun did. My approach is a little different. Well, historically, you have got 6 infectious exanthemas like measles, scarlet fever, rubella, 4th disease, erythema infectiosum, otherwise called as 5th disease, and rogeola. Majority of the exanthemas are non-specific and cannot be accurately assigned to a discrete. Typically, they are self-limiting and resolve spontaneously within a week. Very difficult to just understand these classical 6 infectious exanthemas. But, well, what is important in this is even the day of appearance of the rash is very important. So I have got a mnemonics wherein you find very sick person must take double tablets. Very means varicella on the first day, and scarlet fever, sick, that is day 2, person pox, smallpox, day 3. We don't see now smallpox. Must is measles on day 4. Take is typhus, day 5. Double is dengue fever on 6th day, and tablet typhoid on 7th day. It is just to find out what day the rash appears, so that may give you some clue. But invariably, if you go through all these, measles, scarlet, rubella, erythema infectiosum, everything's look alike. But similarly, if you take measles, scarlet, and rubella fever, everything starts at hairline or begins on the face and spreads inferiorly. But how do you differentiate? Then you have got coplic spots in measles, so you must examine the mucous membrane. Pastia lines in scarlet fever and also associated symptoms. And rubella, you've got lymphadenopathy and arthralgia. And erythema infectiosum, what is important is rash, waxes and veins, and over several weeks, then there will be arthritis and there can be aplastic the crisis also. So I have a picture of a picture where you can see the blanching, which is so evident, and sandpaper-like lesions, perioral sparing, white strawberry, and then going for red strawberry. Well, the diagnosis is scarlet fever. What you get is sore throat, circumoral oral pallor, antecubital fossa petechiae, pastia lines, rash will be sandpaper, and there can be lymphadenopathy. It is due to the erythrogenic toxin, and tongue already I have shown you. And then there are other diseases, but I'm not going into each one. I would like to only highlight two things, varicella and Coxsackie virus, which we get hand, foot, mouth disease. But here, the most important point which you should remember is the type of vesicle, elliptical versus round. You find vesicles on erythematous base which are round in varicella, whereas elliptical in Coxsackie virus. We'll see here a fever with pleomorphic rash, which is very typical of varicella, where you get clear vesicles on an erythematous base. What you also see is pleomorphic. You have got macule, vesicle, and already even crusted lesions also. In the same area, you get all type of lesion that is pleomorphic, not polymorphic. Well, then even in newborn, you can get similar lesions, and this is a very interesting case of neonatal varicella. And how do you approach is an important point in neonatal varicella. If the maternal exposure is there, the onset of maternal varicella more than 7 after delivery, it is low risk, likely to be a mild disease. No treatment is necessary. If severe disease, IV acyclovir. Whereas onset of maternal varicella 7 days before to 7 days after delivery, this is high risk. So you have to give VZIZ if not already given. Otherwise, you have to start IV acyclovir. In non-maternal exposure, 7 days of life or more than 7 days of life, you have to give, if it is less than 7 days of life, the immunoglobulin can be given, and otherwise IV acyclovir. Invariably, it is very difficult to get IVIG, the varicella zoster IG. So what we do is IV acyclovir. If severe disease, yes, regardless of the serostatus, you must start IV acyclovir. And the another child, so some lines are going on. If there is anybody doing, please just check it. I was telling you, the lesion should be elliptical. You can see here the elliptical lesions, here also hand, foot. And what is more important, they heal with a crusting within 8 to 10 days. And I always see the perianal area, which is very characteristically involved in hand, foot, mouth. Yes. Okay, I think now you are able to hear. Hello?
Yes, sir.
Yes, yes,
Yes,
we are able
yes,
to
yeah,
hear,
because
Arun bhai.
Yes.
there was some unmuted come. But what is more important, a lot of us people see here, especially the southern Maharashtra and even in a place like ours, we see the hand, foot, mouth disease. But what we see, our role is at only grade 1 or uncomplicated hand, foot, mouth disease. Just have to have a symptomatic treatment, and If there is no warning signs, you have to just keep it quiet. But there are gradations where you can get aseptic meningitis or severe cardiopulmonary failure and all. So what you should tell is, you see, but any appearance of these things, for immediately the child has to be taken care by the pediatricians. Our role is only till grade 1. And we can also get arbovirus exanthemas, which are very commonly seen in India. Number 1 is dengue fever and dengue hemorrhagic fever. Well, and then you have got chikungunya. Almost 40 to 50% of the time you get the rash. And the other things which are mentioned as arbovirus exanthemas, like various other geographical areas, we don't see in India much, but very recently even Zika virus was seen. Zika virus was seen in Kerala, and in 1 or 2 cases were there in Karnataka, also in Shivamoga, I believe, if I'm correct. Well, this is a very typical picture of a child with biphasic fever. You got maculopapular rash, confluent erythema. What is highlighting point is white islands in the sea of red. This is very classical of dengue, which you should appreciate, these white islands in the sea of red. So the other presentation would be arthralgia, myalgia, bleeding gum, epistaxis, headache, retrobulbar pain, crusted lips, and one prostration, which is very commonly seen. Even again here, red, the white islands in Red Sea, which is suggestive of dengue hemorrhagic fever. Well, there can be sometime febrile infant with ecchymatic rash and vesiculobullous lesions. This is very common in nowadays with this chikungunya season now at our places. So this is very classical chikungunya lesions, where you get the vesiculobullous lesions and also ecchymatic rash. So if you find children with, especially what happens is, this is called as terminal rash. Fever stops and rash appears, usually the extremities, which is commonly a non-inflammatory vesiculobullous lesions, and eventually within a week or so, they will disappear without much the complications. But of late, what has happened is, even you should be very careful, even the chikungunya can present with the neurological manifestations. So please be aware of it. And if there is any change, the pediatrician should also be involved. And then there are other viral hemorrhagic fevers of a different geographical areas, which I'm not going to deal, because we see in India dengue fever and dengue hemorrhagic fever, which I already shown you. And in place like Karnataka, where the Shivamoga district, we get the Kashnur forest disease. This KFD virus disease is also seen in Saudi Arabia. What happens is the red eyes, headache, bloody nose, skin petechiae. Again, it is a viral hemorrhagic fever, particularly in a particular geographical areas. And then you can also get common infectious agents which can cause exanthema and enanthemas due to the viral causes. What we see is herpes simplex virus 1 and 2, and varicella zoster virus. But they will not be generalized unless an immunocompromised individual, a varicella zoster with the extension or disseminated, then you get the generalized rash. Otherwise, what you get is human herpes virus 6 and 7 can cause reactivation. The diseases which are caused by these are called as paraviral rashes, like Pityriasis rosea, atypical exanthemas, DRESS, and the other diseases also. Well, and you can also get the other diseases, especially due to the bacteria, which we can get rash in Indian scenario, is rickettsia, and also Neisseria meningitidis can cause rash. I'll just show you another thing is the streptococcus, which can also cause toxic sac syndrome, and staphylococcal aureus, which all of you know, staphylococcal scalded skin syndrome. I'm showing you a picture of a child with the strawberry tongue, exfoliation of the hand and foot, very characteristic peeling of the skin. But it's not just that if you find it, it is toxic sac syndrome. Usually there will be rapid drop in blood pressure, confusion, diarrhea, sudden high fever, low urine output. All these things are, if they are included, then it is toxic sac. And this is very classical picture. You can see the Nikolsky sign and generalized rash, peeling of the skin. Well, another child with a neonate with a flaccid bulle. Again, Nikolsky sign is positive. We can also see sometimes little infants and children, fever, irritability with the diffuse erythema and going in for exfoliation. Very classical picture of staphylococcal scalded skin syndrome. All those pictures speak a rash due to staphylococcal toxin. Well, sometime you get a child with bilateral periorbital edema, suffusion of the conjunctiva. I was telling you, you have to examine the conjunctiva, whether for injection or a red eye, and then edema of the hands and foot, frontal headache. They are all highly suggestive of rickettsia. So rickettsial fever is another thing. We get the generalized rash, and these are the other things which you should know. Edema of the hand and foot is very important, and generalized petechial rashes. Sometimes the rickettsia can present with end anginitis. What is meaning is the end arthritis or the thrombus phenomenon will be there. Where do you get the necrosis of the ear, necrosis of the tip of the scrotum, necrosis or gangrene of the tip of the digit, which is very classical. Again, it is a rickettsial fever itself. The drug of choice is doxycycline. Sometimes you get reticulate erythema and geographic areas of necrosis. Well, this is meningococemia with purpura fulminans. You can also get other agents causing some cutaneous manifestation, but not very much generalized. So I have not discussed, because whatever we see, I have just tried to show you. So what would be the diagnostic algorithm to approach? One is history. I have already told you. Temporal correlation for drug, temporal correlation for the day of the appearance of the rash and how they proceed, and the rash morphology. It depends whether it is macular, papular, vesical, bulle, or ecchymotic lesions. And other system involvement is very much important. You must see the reticuloendothelial system, and you have to categorize them, what group of manifestation, and then you do the investigations. Well, the laboratory diagnosis, specific serology is not sufficient by itself to identify an active infection. The detection of pathogen-specific IgM reveals a viral reactivation or a primary infection. IgG seroconversion is considered evidence of infection. At least 4 times difference in IgG titers in 2 consequential samples collected in the acute and convalescent phase. This is very much true in chikungunya and dengue. Nested PCR techniques can be used to detect the viral DNA in plasma or serum, a well-known marker of active viral replication and active infection. Although culture tests are slow and have low sensitivity, they remain the gold standard for diagnosis of infection, for which molecular methods such as nested PCR are validated. Again, in conclusion, the understanding the etiology of atypical exanthema, especially the infectious ones, remains difficult but crucial for the patient and community, considering the issues such as time off school, immunization schedule, risk for pregnant women, and immunocompromised patient. However, the morphological pattern, seasonal occurrence, presence of exanthema and enanthema, and systemic symptoms may offer the physician or the treating dermatologist important clues to make a quick etiological diagnosis, which, if confirmed by test, ensure timely and appropriate treatment. What I shown all these cases were just to find out how clinically you can become aware of those things and do necessary diagnosis. It is just a flow chart of a preclinical approach used to determine possible viral etiology of exanthema. Very difficult, abuse thing. Probably if anybody is interested, you just mail me aruninamdar@gmail.com. I will send it. Well, I must thank the ISPD people. I'm also part of ISPD rather, for giving me an opportunity to talk on this. For rash decision making, well, you have to observe, think, proceed with the action. Thank you very much.
Thank you so much, sir, for your excellent talk and simplifying how we can approach a child with a generalized rash. Next up, I'm delighted to introduce Dr. Ram Gulati, sir, who will be our moderator for the panel discussion. Sir is a consultant dermatologist at Jaipur, and he was a former locum consultant in the NHS Group of Hospital, Glasgow, UK, and also former honorary clinical teacher, University of Glasgow, UK. Welcome, sir. While Sir prepares his slides, I'll just introduce our esteemed panelists as well. Our first panelist is none other than Dr. Sandeepan Dhar, sir. Sir is Professor and Head, Department of Pediatric Dermatology, Institute of Child Health, Kolkata. And Sir has more than 300 national lectures and over 100 international lectures and more than 160 publications to his name. Sir is the author of the first pediatric dermatology textbook in India and has authored more than 5 books and contributors of more than 50 chapters in various national and international books. So, he's the founder president of the Society of Eczema Studies and member of the International Eczema Council and also an F1000 Prime expert on atopic dermatitis, among other honors. Sir has chaired many sessions, delivered lectures on pediatric dermatology, and his area of special interest is none other than atopic dermatitis in various important conferences across the country and abroad as well. Welcome, sir.
Thank you very much, Akash.
Next up, we have Dr. Darshini Satish Kumar, ma'am. Ma'am is a professor, Department of Dermatology, Christian Medical College, Vellore. Ma'am's special area of interest includes pediatric dermatology, immunodermatology, and epidermolysis bullosa. Welcome, ma'am. Next up, we have Dr. Neetu Bhari, ma'am. Ma'am is additional professor in the Department of Dermatology, All India Institute of Medical Sciences, New Delhi. Ma'am has more than 150 publications and more than 50 chapters to her credit. Ma'am won the first prize in the International Society of Dermatology quiz in the International Congress of Dermatology 2014. She has received the KC Kandhari Gold Medal Award for being the best postgraduate at AIMS 2013. Ma'am's areas of interest include pediatric dermatology, dermatopathology, STI, and contact dermatitis. I also include Dr. Arun Namdar, sir, who will also be joining the panel. So, without further ado, I'll pass on to Dr. Ram Gulati, sir. So, you can take up the panels.
Thank you very much, Dr. Akash. I'll just share the screen once you take it.
Yes, sir. I'll stop it. Yeah. So, you could make it full screen, sir.
Yeah, I think it's a full screen now.
Yes, sir.
Right. Many thanks, and I think welcome to this wonderful evening. And we had two very informative talks, and they covered a lot of infectious granulomatous disorders and the ones which can present with rashes. I think sharing experience is the best thing that we can actually do. And I welcome my panelists here to share their experiences of how they deal with the infections. So my first question would be it's almost to everybody, how commonly do you see pediatric infectious disorders in your clinic? Kind of a percentage of the pediatric patients that you see, and which infections are more commonly seen? Maybe Dr. Arun Namdosa, you can start with that.
Well, now infectious disease in pediatric or adult, it is the fungal infection, dermatophytosis, especially even in children also. But otherwise, whatever I have talked, this is a season for now the chikungunya. We do get chikungunya patients quite common now. Otherwise, whatever we talked about the viral exanthemas, which is a general terminology simply because it's very difficult to, I have already told you how difficult it is to delineate all the viral exanthemas. So that is another common thing.
Absolutely. So, Dr. Sandeepan, do you concur with that? Any difference in the way you find the conditions in your area?
Yeah, I think there are a few parameters or variables. When I see patients in Institute of Child Health OPD, mostly it is infections, apart from Second comes the inflammatory conditions. And that also is variable, as Arun bhai very rightly pointed out, the season wise. During summer and the rainy season, we see more of infections. Transitional period, we see viral bacterial infections. In my clinic, I see very less of infections, mostly the inflammatory conditions, like atopic dermatitis, psoriasis, and autoimmune conditions, lichen planus. Those type of cases I notice. So
Right.
it is variable in which setup you are seeing the patients and in which
Absolutely.
season you are seeing the patients.
Absolutely. So this was one of the studies from Kolkata where they tried looking at the percentage of pediatric dermatosis, and they found that almost more than half were infections and infestations. And among them, dermatophytosis, as Dr. Arun Namda said, was the most common. And then there was a significant inverse association with the socioeconomic status. So I think if you're seeing cases where the socioeconomic status is very low, you might find more of infections.
Infections.
I'll just show a few pictures. So you can see this little one. You've got a big patch of, it's very clear-cut tinea. And then you've got a lot of small annular lesions among that, ring within the ring appearances. And then these genital tinnias, which were not very frequent at one point, become more frequent. And maybe these infiltrated kind plaques and psoriasiform lesions of extensive tinea in adolescents. And then you start seeing these side effects of the medication that you use. So extensive use of clobetasol across the body, causing local striae as well as the Cushingoid features. And then the significant striae in a localized area. So, and who is responsible for these catastrophic clinical presentations? So at one point, I think after COVID, we thought that the whole epidemic was going down. But again, you start seeing these patients again. So maybe I could bring in Dr. Neetu Bhari here. So sitting at AIMS, do you still see these things, or are they much more common in the periphery?
We definitely see Dr. Ram, and as you know, we have a separate room for fungal infection. This is as common as that, and majority of them, they are steroid modified in one way or other. The example you have shown is an extreme example where there is significant amount of modification, but we see all degrees of modification, maybe just a small treatment unresponsiveness because of the topical steroid abuse, and full blown tinea incognito because of the extensive topical steroid abuse for many years.
Right.
So, and over the counter, as you have written, availability of the drug is responsible. The quacks, nearby quacks, which are treating the tinea with these drugs, they are responsible. Though IAD will now has taken this mission as their primary goal to spread the awareness, but I think still we are falling short of it, and all of us have to take responsibility also to spread this awareness.
Absolutely. I think I was just coming on that. So 2019, we had the slogan for the ideal theme for that year was fight the topical steroid use. So it's been 5 years down the lane. So 5 years of this stewardship, have you seen a change in the way these creams are? Have they come down in the market, or is it still the same?
No, I don't think so.
Anybody else who has got any experience there? Do they think the number of cases have reduced, or
No.
no?
It is
So
more or less the same.
absolutely. I think the cost implication is again because
It's same.
itraconazole is
Probably yes, sir. Why
yeah, carry on, Dr. Arun. Yeah.
Why it is persisting is what has happened is it responds to itraconazole. I just using the drug name itraconazole, but the duration is it has to be almost 3 months now. That compliance is not maintained by any patients. So, and then the one family member get affected. The infectious nature of this newfound tinea indotinea, I'm not getting the name,
Indotinea.
Indotinea. So that's the reason for in 60% of the cases. So it is widespread. It needs longer treatment, and it's not that you should give 200, 300, something of that kind, or 500 of those things. Even if we give whatever amount we used to give, but duration has increased. So that duration cannot be taken from the patients. Number two, as soon as it disappears, people think doctor is telling unnecessarily, chalo, 3-4 mahine, why should we take? And they come again. So that's the story.
Absolutely. So you are in favor of prolonging the treatment rather than hiking the dose. So even though different people have got a
Yes,
different
yes,
way to treat it,
yes.
I mean, Dr. Darshini, I'll just bring in as well. Dr. Darshini, uh, definitely we have gone through a couple of features of that, but bioavailability of different brands was an issue at one point, and you used to see all these granules and number of granules, etc. With the availability of super bioavailable, do you think that particular kind of a controversy has settled, and do you find super bioavailable better, even though you don't have it in the pediatric age group, but adolescent age group, yes, you are giving it.
I don't use much of the super bioavailable brands. I still stick to the original ones, but with the particle size which are small. I'm not here to tell any specific brands, but I think definitely there is a role of which company or brand you prescribe, because there are a lot of itraconosols available in the market, but all of them don't work. So the particle size definitely make a difference. In my practice, I have found that that does make a difference. And there are a lot of people, my colleagues in neighboring colleges and all, who say that the super available, bioavailable brands work much better than this, but I don't have much experience with that super bioavailable. And one more point which I would like to add to the previous panelists is that not treating all the family members is one of the main source for this dermatophytosis lingering around again and again. And it's a big problem in those children who are in the hostels. So most of them give the clothes for a common laundry, or they have a common washing machine. So even if you try to treat the child, there is a continuous a source of infections posed from the colleagues or the hostel mates, which also has to be factored in while you're giving treatment.
Absolutely. So I think education has a big role to play. And do you think, I see a lot of prescriptions actually being given for 7 days, 14 days. Do you think we should just give it for a month at
Yeah,
the same course so at least the number of visits reduce?
I
yeah.
do prescribe now, have started prescribing for a month
Right.
minimum.
There was a small kind of a query of use of antifungals in agriculture. Does anybody believe that that has got a role to play in triazole resistance as well? Dr. Sandeepan.
I don't think since
Yeah.
ages we are using the
Yeah, Dr. Arun, go on. That's fine.
antifungals in agriculture, and they also keep changing also. Sorry.
I did Arun bhai.
Right, fine. I mean, general practice, we don't have any guidelines here at all. So you see the registered medical practitioners actually giving out itraconazole just for 5 days, and then maybe stop it, and then 7 days. Some people give it for keep on carrying it for 3 months, 4 months, but with a mixed fixed dose combination creams, clozapine, clobutazole at the same time. So do you think the country needs kind of a clear guidelines for general practice here? Dr. Sandeepan, you
Yes.
have it.
Yeah, of course. I think that's the most important thing. What Dr. Arun said at the very beginning, it is not the hike in dose, but rather than prolongation of the treatment which makes the difference. And I have seen in my practice that the patients who disappear after 1.5 months, thinking that it has cleared, they come back within next 6 months. And those who continue religiously and follow the advice, take it for 3 months or even sometimes 4.5 months, 4.5 months, even I have given to up to 6 months, to adolescent boys and girls. And they are in remission for, few years over last few years. So that makes the difference.
Right. Maybe somebody who has taken an oral steroid for a long time or topical ones for a long time, the high potency may need a longer period of
Yes,
time.
yes, absolutely. Absolutely.
Right. Dr. Neetu, the role of environment, I mean, we're thinking of global warming. So maybe that is that is causing the hot and humid environment, or is it not just the environment, it is the hygiene, the fomites, the family members you said, and the rising trend of obesity at the same time and the tight clothes. How much do you think these have a role to play? Again, the education will come in as a part and parcel.
So I think this is an important part of management counseling regarding those at least modifiable factor. Though we know that there are certain unmodifiable factors as well, whether this is related to the organism or related to the species which is becoming more prominent, or the immune response is being modified. But whatever modifiable factor we can modify, and we definitely see there is a great contribution to those as well. So I think it forms a major part of practice.
Right. Dr. Arun was raising a hand. Dr. Arun, you have something to say.
Yeah, yes, it's genes. GE genes, not genes, GE genes. And the very concept of genes is that you don't have to wash every day. So that is one thing. A tight genes Everybody uses, and that I'm not telling that is a cause. That is one of the factor which is, and suddenly, of late, with due respect to my all sisters and uh, children, especially female, they started using these leggings which are so tight and hardly you can breathe there. And similar, it's I would say the sister of jeans. So that also is helping to, especially only gluteal region for a long period. They keep sitting without a break. All these soft worker or even the students, and you see only there the lesion. So we should explain those things. Probably the cloth has a role, especially these jeans and leggings.
Right. So maybe
Okay,
the
they
topical
should
steroid
use it,
fine
but
is
for a shorter period, whether they wash it or not. Especially concept of gene means no wash.
absolutely. I mean, there's a GENES has a bit of a role to play as well. So if you've got a
Yes,
very extensive tinea and you're not coming to the conclusion as to what caused it, then we have seen TH1,
true.
TH2 imbalance patients with atopic dermatitis probably causing more extensive tinea. Dr. Dhar can probably show some light on that.
I think you're very right, Ram, mentioning about the GENE also, because there are many cases where we don't find any underlying immunocompromised state, not at all. But still, there, dermatophytosis is not only extensive, it is recalcitrant also. So the best possible treatment also not going. Why it is not going? Definitely, there must be some, genetic mutation or in the fungus or the genetic or the HLA pattern of the individual, which needs to be investigated. And this is the big area of research, I believe, for those who are working in this field.
Absolutely. I just brought in this issue because if you are completely stuck with and not able to find a reason, do think of the genes as well. Dr.
Absolutely.
Darshini, what about the
Recently,
fungal thing? Have you
recently we
found?
s-
Sorry, yeah, carry on.
recently we saw a case of CARD9 mutation with few hypomycosis. So
Right.
there it was proven, the mutation was proven, the patient had systemic manifestation. And then we reviewed the literature and found that CARD9 is an important mediator of fungal induced immune response and neutrophilic recruitment, etc. But I think I agree with your point that maybe in the superficial dermatophytosis also it may play a role. And as sir said, the studies, the further research will tell us more about it.
Absolutely. So,
Right.
Dr. Darshini, what about fungal drug resistance? Have you found much of fungal drug resistance in your practice?
Yes, sir. I think the terbinafine resistance is highly prevalent. There was a study conducted by some of our colleagues in our center also, wherein it was found that terbinafine resistance was very, very high among the dermatophyte species.
Right. So
And now hardly we prescribe terbinafine actually because none of them work.
I think there was a kind of a thought that if you've got a naive patient, you can probably prescribe, but you hardly get a naive patient nowadays.
Ah,
It is the chemist who's already been the primary caretaker. And as Dr. Arun Namdar already said, Tinea indotineae, the trichophyton, this species actually is just a variant of Mentagrophytes type, it's a type 8. And 71% isolates nowadays are demonstrating terbinafine resistance. That was in study. It's been a while for the study and it has increased, I think. Just a quick question on one thing, the role of topical tacrolimus. It's an interesting article in adherence to antifungal therapy in resistant recalcitrant tinea incognita. This is a very small study, 28 patients. And what the thought was that when the patient has come in with using topical steroid for a long time, the moment you take the steroid off, the patient actually has a significant flare. And that way, the adherence to therapy is actually compromised. So they started using tacrolimus to just reduce that flare. So it is not a big study. So how many believe that this thing works and anybody has used that? Any experience of using tacrolimus for the first few weeks? They did a study in for 12 weeks and they found that the ones who had tacrolimus actually
no,
adhered
I
much
don't.
more than the ones who did not have tacrolimus.
I mean, Ram, theoretically it may sound well, but
Yeah,
I think practically it is stretching too much,
Yeah.
too far stretching of imagination.
absolutely. But it's an immune suppressive. So at the end of the day, patient may start
Yeah,
using. The only way he may not start or she may not start using is it's a costlier drug. So, so maybe they're not going to overuse it.
true.
Just a quick one. What medication regime would you consider as a first line? Would it be itraconazole for everybody now? Or any change? Or do you start with itraconazole in almost all the patients?
I
Or
think
the
it depends on
children,
the
do you?
age also.
Yes, if you're
Yes, yes.
Mhm.
What about the infancy?
Basically, sorry, Darshan, please carry on.
No, so please get.
So itraconazole, we are carrying out a study in our institute in collaboration with the microbiology department. We are doing fungal PCR also. And itraconazole, I am very much comfortable of giving itraconazole even in 1 month old baby also if there is a need, because the itraconazole syrup is available. Because in our institute, the critical care pediatricians and infectious disease experts, they are giving itraconazole, oral itraconazole for systemic candidiasis. So, even in newborns. So there is, if you go to the literature, you will see it is safe even in newborns. So I don't think there is any need of placing panic button as far as the age of itraconazole is concerned.
Yeah, and you've got a oral solution for that as well.
Yeah, we have got a oral solution.
So that answers the question in the chat box: from what age can we start itraconazole oral for kids?
Correct.
But griseofulvin we are still using in children, particularly, especially if frenia capitis is there.
Yes.
So griseofulvin is also one of the antifungal. Terbinafine, I think, has lost its charm over the years.
Absolutely. So, anybody who would give a short course of a topical steroid?
never.
Never.
Because what happens is whatever science or whatever education you give, what makes them more happy, they keep continuing and then end up with what should not have been. So don't ask them to taste the best thing first.
Absolutely. Dr. Thir, do you have a message for the general practitioners and the dispensing chemists, which might actually just ease off this difficult to treat any epidemic?
Are you asking me?
Yes.
Sorry, I didn't get your point, Ram.
The general practitioners and the dispensing chemists, should they do something so that this epidemic can ease off?
Yes, dispensing chemists and general practitioners, whenever I talk to the pediatricians as well as in to general practitioners, though rarely nowadays, I always emphasize on not to use combinations of steroid antifungal and antibacterial or steroid antifungal. I tell them that it might take some time, but be patient and do counseling rather than giving a wrong prescription. So if you spend 5 minutes time more with the patient, that is always better than writing a steroid antibiotic combination, antifungal combination, because the patient may be very happy for next 2 weeks, but after 4 weeks, the patient will switch over to another doctor.
Absolutely, and maybe make use of the friends dermatologists who are there.
Right.
So maybe just sending a photo actually makes it as well. I'd probably skip that. So this is a case. This is Dr. Bhari's case, and she was kind enough to give it here. So it's a 6-year-old female child with a few months history of developing these light-colored flat lesions on the forehead, and they gradually increased in number, completely asymptomatic. The rest of the dermatology examination was fine. She's otherwise well. There is no significant past or family medical history at all. So what possibilities do you think you keep with this case, Dr. Darshini?
Maybe Verka plana, sir. That will be one of the differential considering the location and the morphology of the lesion. They're all papules, is that right, sir?
So they look like very flat lesions, actually. It was very difficult to say. They look like very flat lesions.
Neetu would probably say they were papules.
Most of them were papules. Some, as Dr. Ram said, they were so thin that you can't distinguish macule versus papule. So macule to barely elevated papule.
Epidermodysplasia vericiformis can be thought.
That is the other thing I was going to say. It depends on the extent, how extensive it is will be the next question. Because if it is just on the face, EDB may be unlikely. If it is more extensive, P epitras versicolor like lesions, atrophic lesions, EDB will be one of the differential.
Just on the forehead.
Yeah, Dr. Bhari, you want to add something?
And
just on the forehead. That's answering Dr. Dash's question. Yes, sir.
Was there any atrophy-like thing in this?
Atrophy, sir? Did you ask atrophy?
Atrophy.
No, sir.
No, okay.
No, sir.
Very recently in new edition of New England Journal of Medicine, very recent articles, one of the articles says atrophyifying vitreous versicolor. one of the conditions they have mentioned. I just thought of it.
Yes. So I've got two cases of atrophic fine versicolor, but they have been using
Yeah.
steroids for a very long time. So only the lesions remained atrophic, rest of the skin actually recovered for some reason.
Yeah,
So now histopathology was done. So mild hyperkeratosis, upper dermis, mild infiltration of histiocytes and few lymphocytes, and rest is unremarkable. So any thoughts on that? Does that change the scenario a little bit? So they could not find anything specific for verruca plana, or maybe anything.
Right.
So at that point, topical tacrolimus was given and offered, and the child comes back in a year's time. There is no new lesions, but there is no improvement either. And the management was we do a photographic documentation and we continue, but then again lost to follow up and comes back in a year with no improvement. So what kind of an approach now we actually take on this case? Dr. Darshini, any thoughts?
Topical retinoids, if you're considering verruca plana or
Definitely possibilities were as we've discussed before. So maybe an acquired EDV, because definitely EDV would have started much earlier, and possibility of low. But again, the child is not immunocompromised, so thinking of even acquired EDV is difficult. And then rest remains the same. There have been case reports of idiopathic gutted hypomelanosis like macules in children, and then vitiligo possibly an early one, but it would have actually become more depigmented. So the thought was to actually do another biopsy, but the child was unwilling, the family was unwilling. And definitely you ended up with giving tretinoin, 0.025%, considering it to be verruca plana. That's what it looked like, and this is after 3 months. So it clears off with 0.025%. Uh, I think the doctors probably are primarily an investigator and secondarily a doctor. So that is what I would say, that it is almost thinking out of the box when you're completely stuck and the histopathology shows something different. But that much depends upon the site of taking the biopsy as well. Sometimes it is not the best site, but it has been taken. And children, you don't want to repeat it unnecessarily. And it is just the
And
clinical features which guide you through.
another important thing, I'm sorry to interfere.
Yeah, no, carry on.
Another important thing is that whether the slide was reviewed by a qualified or an experienced dermatopathologist, because there is a huge difference between a dermatopathologist and an ordinary histopathologist. By and large, ordinary histopathologist hardly has got any clue as far as the dermatopathology is concerned. It is a totally gray area for them. So that makes a difference. The description, histopathological description we missed out on, verruca plana, perhaps could have been picked up has this been reviewed. I don't know. Since it is, Neethu's patient, I'm sure it is, dermatopathologist, there are a lot of dermatopathologists seen the department they have seen. So, otherwise, if the patient is from outside, the biopsy was interpreted outside, then probably I'll keep my finger crossed as far as the histopathology report is concerned.
Right, sir. So I want to make a point, since this is a panel of pediatric dermatologists, that's why probably Dr. Darshini could pick verruca plana as a first differential diagnosis. But otherwise, whatever we read, we see verruca plana as skin color to lightish brown, hyperpigmented papillary lesion, and hypopigmented papule is a very unlikely presentation. And that's why the child, when was seen by dermatologists who are not pediatric dermatologists, they thought of lichen sclerosis as their first possibility because of the color of the papule, though there was no atrophy, there were no follicular plugging or telangiectasia or other features of lichen sclerosis. After 1 year of treatment, when I saw her, and I had previous experience of seeing children with acquired EDV in a patient who had nephrotic syndrome, patient with verruca plana presenting with hyperpigmented papule. So probably that's why we could pick in spite of absence dermatopathological changes. And the other reason of absence of histopathological changes may be the smaller lesion, small size of the lesion. So biopsy may miss it. You may need various step cut to get the proper result. But luckily, she responded well. Not every patient of verruca plana will also respond to topical tretinoin, but this patient responded well.
That's what
Thank
I
you.
wanted to say. Sir, Sandeepan sir, we have also found that verruca plana, though we have sometimes biopsied a very classical lesion also because patients are very worried and all, many times the pathologists are not able to see all the features and say it it's a acanthotic lesion or something. The specific features are often missing. And retinoids, we do also prescribe, but this is a tremendous response. I haven't seen such an amount of clearance with topical retinoids for Verica. It's a real amazing response for this patient.
Absolutely.
I think it was justified after 2-3 years.
Both the clinical diagnosis and the response both are amazing.
Absolutely. So this is a 16-year-old boy with severe nodular cystic acne. Has been on Ayurvedic oral and topical treatments for last 1 year, but significant flare in the past 10 to 15 days with marked seropollen discharge. The boy already had a 10 to 15 days course of coamoxiclav and then had at least 2-3 antibiotics before he landed up. And it more looked like follicular inflammation initially. So pus culture and sensitivity was done and MRSA came out. And he responded to a 2-week course of linezolid. At least the flare subsided significantly. How much, so even though it's a background of acne, it looks like, but how much do you see MRSAs in your clinical OPDs, community acquired MRSAs, where you get pyoderma and it is not responding or partially responding to the oral antibiotics unless you give something which is targeted towards MRSA? Dr. Arun.
Well, especially what happens is when you diagnose similar condition, if I had seen without doing culture, or okay, I would have suspected gram-negative folliculitis, and I would have added either doxycycline or the cotrimoxazole would work very well. So, well, as I have not done the culture studies in such cases, probably I'll not be able to comment whether MRSA was there or not. But as it responds to cotrimoxazole, I always be happy with the results. So that's the thing.
This patient was started on doxy while
We
awaiting
did
the culture.
study in pyoderma
Came
with
again.
yes. We did some study on pyoderma with MRSA. Study was done. Quite common. Percentage I don't remember now. The study is a long time back, about almost 7-8 years back. We did it. But in practice, what I do is I add cotrimoxazole. Invariably, it helps.
Right. That's one. Even though doxycycline works for MRSAs as well, but the question was to just change to linezolid. And anybody has other experiences with MRSAs having causing issues in their clinical setups?
I mostly see the kind of MRSA in our institute. They are hospital acquired MRSA because of several factors associated with admission. Community acquired MRSA also, I have seen, but not that common, I must say. This particular article you quoted, Dr. Ram, is very good because I was the editor of ISPD that time. So Dr. Uma Shankar, Nagayu and team. I think this is one of the very few, studies which are published in pediatric population. Of course, Arun Bhai has published. This highlights the community acquired MRSA, to which is responsive to usually to sulfamethoxazole, trimethoprim, cotrimoxazole, or even doxycycline. But by and large, for MRSA of both types, hospital acquired and community acquired MRSA, linezolid or vancomycin, they're the drug of choice.
Absolutely. So in this study, they found that 6.5% of their children had community-acquired pyodermas with MRSA. And nasal colonization was found almost 60% in the study. The reason I brought out was the use of mupirocin. I think it is so much rampant nowadays. So it was supposed to be actually kept only for MRSA, decolonization. But now we have got all this MRSA which are resistant to mupirocin. And that is where nowadays ozenoxacin comes in, because it is the MRSA are still sensitive to ozenoxacin, those which are resistant to mupirocin. So how much we should actually not use these two for day-to-day infections, Dr. Neetu?
So one point I wanted to add about MRSA, Dr. Ram, is that if a patient is coming with impetigo, a child is coming, then I think we see it less often. But in patient of atopic dermatitis, patient of immunodeficiency with recurrent infections, then probably community-acquired MRSA is of higher frequency. Arun sir want to add something, I think.
Yes. Dr. Arun.
I just, before this webinar, I was going through one of the articles where they wrote delafloxacin only 1 mg per kg. That is 0.5 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 only quinoline that provides MRSA coverage. I don't know whether it is oral or not. I didn't go through it, the whole article. I just thought because MRSA you had written in the WhatsApp group that we'll be discussing. So this is a new drug, delafloxacin, only quinoline that provides MRSA coverage. It's just addition to
I think that
for
is
all
one
the
front
colleagues
where we are
to
not
know
doing
it.
very well of bringing up good antimicrobials. So it is only once in a while that you get a new antimicrobial, even though you're getting your biologics at a larger pace. Um, so I think antibiotic stewardship is needed, and we probably need antibiograms locally where we know what to do and what hierarchy to actually form when we're giving antibiotics. So this is another case, 16-year-old, an ill-defined hypopigmented patch on the right cheek, present for last 2 years, otherwise well. And this is a known case of Hansen's disease. So when she came, she already took 6 months of PBMDT after having histopathology proven Hansen's. A biopsy was taken at the 6 month because there was no change in the patch. And then after the biopsy, the activity was found and was put on MBMDT for another 12 months. So when she came around, she already had 18 months of MDT taken for a single patch. And biopsy post 12 months was done, which did not show any evidence of active Hansen. So MDT was stopped. There was no perilesional nerves. Now, the concern was at 16-year-old about the residual hypopigmentation. And this child, the parents are looking for a groom. So it almost amounts to a child marriage. So the first thought in the mind was actually give them a placebo so at least the child marriage doesn't happen. But at the second time, I think the child is actually very anxious with this hypopigmented patch as well. So any thoughts on how to take care of the residual hypopigmentation when the Hansen is not active anymore? Um, Dr. Darshini.
Sorry, sir, I don't do anything specific for this except for counseling them. And many times over years, it tends to lighten further, but I don't think it can clear completely. I have not given any specific medications for this post-inflammatory hyperpigmentation following resolution or treatment of Hansen's.
Right. Dr. Neetu?
Can tacrolimus be your placebo? Because I'm not sure of the
Right.
efficacy of the tacrolimus. Though we have used it in like post-inflammatory hyperpigmentation of lichen sclerosis, sometime like in ORS, but not in Hansen. In particular, Hansen case I have not used, but other post-inflammatory hyperpigmentation we have used it occasionally. And there also we are not sure whether this is contributing to the response or not. So if you want to choose a placebo and if it is an expensive placebo, tacrolimus can be one and we may try it because theoretically there is a push to the mechanism of repigmentation, but I'm not sure the actual contribution to the response.
Right. I think it's not a very usual scenario. Dr. Sandeepan, any?
Yeah, basically we do not know the reason of hypopigmentation in leprosy, entire spectrum of leprosy. So there is no melanocytic changes, no changes of melanocyte to keratinocyte transfer of melanin. So we do not know the cause. So without knowing, I don't think we should, try anything else. But maybe at times in clinical practice for patient satisfaction, you have to do something about it. But I'll just simply go for moisturizer. If it is my patient, I'll just go for moisturizer and I'll counsel the patient well and tell that, look, wait for 2 years or so. It might gradually get faded out.
I thought so because that takes her to 18 years at least before her marriage. So,
Yeah, one more.
Dr.
Yeah, I agree with because the very reason for hypopigmentation is autonomic disruption, isn't it? So it is less sweating, and so liberal moisturization, and as it is over the face, most of the time, even the ultraviolet rays would help to repigment in certain number of patients, unless the covered area. Yes, I also agree with Neetu that we can use pimecrolimus. Sometimes what happens, pimecrolimus in steroid-induced, intralesional steroid-induced depigmentation or hypopigmentation, it does give result. Whether it repigments on its own or I don't know, but whenever I use it over 6 weeks or about 3 months, usually there will be repigmentation. If it is no atrophy, only hypopigmentation due to the intralesional injections, especially triamcinolone. With that, I would go with emollient and in case, well, pimecrolimus.
But I would like to know from Dr. Nitin, in this particular case, was there any history of using topical steroid on this hypertension?
This is not my case, sir. So
This is my case. This is my
Okay.
case. So there is no
Okay.
use of steroid. Actually, we
No
did
use
not
of
use
steroid.
anything apart
Okay.
than moisturizer.
Okay.
So,
Okay.
so what we ended up giving was a decapeptide solution. We thought it's a very bland solution and just increases melanocyte migration, but did not do anything and ultimately gave up gave a topical Soralin. And at that point, there is this is the photograph sent on the phone by the patient, and they said there is improvement in the hypopigmentation. So at that point, we said to continue and come back in 3 months. But we never saw the girl again. So there is some improvement with the Soralens and how it is working. So it depends upon why the hypopigmentation happens. We don't know. So that is what was done, and it worked. Uh, the next one is a 14-year-old girl who has itchy skin for a few years, and so mild eczema across the body, but having a serosanguinous sticky discharge for the past few days that brought her to the OPD. So it was very itchy and extreme pallor on seeing. So how do you approach this case? So when we did the blood, there was hemoglobin of 5.5 with a low MCV, a ferritin of less than 1, and the rest was absolutely fine. So this is what we did at that point. So we thought heavy head lice infestation with secondary infection with xerosis and mild eczema. An antibiotic was given, the permethrin rinse. A haircut was because if you look at this, the nits are actually going up till almost the end of the hair. So this probably is a very long-lasting infection for years together. So the problem we had is anemia. So this is how she comes back in 7 days after a haircut. The nits are still there, but it looks much more cleaner. So any connection with the anemia for a chronic head lice infestation, Dr. Darshini?
Sorry, sir.
Any
Sorry, missed the
connection?
question. Sorry, sir.
We had a pediatric review done at the same time for the extremely low hemoglobin, and they could not find a reason apart from the iron deficiency anemia. So
I, I I don't know unless the head is so teeming with lice and they are all. I have not seen such a severe case of lice infestation leading to this amount of anemia. So I really can't comment whether that has contributed to the anemia for this child, sir. I'm not sure.
anybody has a case with anemia with a head lice infestation. So this was there for years. Maybe she was there scratching for 8 to 10 years. So there are articles where
Borderline,
deficiency with
some children I have seen having, borderline anemia, but not to this extent, 5.6 gram of hemoglobin. And that can be attributed to lice infestation because lice sucks blood. I think that will also be a stretching of imagination too far. There must be a primary cause of anemia, but as Dr. Darsini says, it was investigated properly in her case, in the case which she had seen investigated properly and no cause of anemia was found. And we see many such cases actually, where we can't establish the diagnosis of anemia. Even the hemato-oncologist also cannot.
So what the pediatrician thought was that there probably was a primary iron deficiency anemia which was nutritional, but probably the chronic head lice infestation actually had worsened it. Because what is known is that they need almost 6 blood meals a day, and the head was full with thousands of lice. So it was something which was very, very out of the ordinary that we saw. Uh, Now, this is Dr. Bhari's case. So, I think he's a 9-year-old boy with a painless plaque on the left buttock with a very slow progression over 3 years. But for the last 6 months, there has been ulceration with a discharge. So, there was no history of granules or blood in the discharge, no constitutional symptoms. There was no history of immune suppression. There was no history of apparent trauma, and there was no significant family history. But if you look at this child was already seen 1 year back, and at that point, this was the way the plaque looked like, and the histopathology showed mixed inflammatory infiltrate in dermis with multinucleate giant cells and dermal fibrosis. Fungal hyphae were not seen, and a fungal culture was negative. So at this point, the working diagnosis was made as entomophthalomycosis, which is a form of zygomycosis. Uh, any other possibilities you can think of with this erythematous plaque, which is covering a large area on the buttock? Dr. Aran.
Can you think of even lupus vulgaris, but no atrophy? Otherwise, any some B-cell lymphomas or anything else?
Yeah, because the histopathology had showed granulomatous inflammation, so there is definitely a granulomatous disorder. Dr. Sandeepan.
No, again, I think in terms of lupus vulgaris first because there is central clearing and peripheral spreading. And of course, one of the fungal infections, zygomycosis, I think that was also thought of. And the third possibility, in case it is persisting for quite some time, then of course the primary B-cell lymphoma of the skin, that is another thing which commonly occurs in children. I mean, out of the all lymphoma. So that has to be followed.
Right. Dr. Darshini, any thoughts on that?
I also could think of only subcutaneous zygomyco. It looks very much like that, as though you can insinuate at the one edge. That's what comes to my mind as soon as it looks. As I had already mentioned, other granulomatous conditions, ICOD and all can be considered, but again, is a very atypical site for just one lesion to be sitting on this region for sarcoid. That's not a common presentation to
Absolutely.
consider them first.
Cutaneous aspergilloma one, I found a few case reports, and that probably looked exactly the kind of a similar thing. But again, it's not a very common condition. The child is not immunocompressive, suppressed as well. So at that time, the treatment was saturated solution of potassium iodide, but there was no improvement, and itraconazole was added at 200 mg per day. So there was good improvement for 3 months, but followed by an exacerbation. So
can I make a comment here, Dr. Ram?
yes, absolutely.
In fact, I also thought of sarcoidosis looking at the very first instance. But the epidermal changes which are seen here, obviously some ulceration, crusting, that is usually not a feature of cutaneous sarcoidosis.
Yeah, so clinically, actually, it doesn't go into favor of either leishmania. It's not an open site. There is no crusting at all. So it's very difficult. So that was probably kind of with the finger insemination test, and it came down as a psychomycosis, most likely. And here we found the ulcers. Now there was no local increased temperature, no lymphadenopathy. The general examination was fine. So any kind of a change in approach now, because the child has relapsed now after itraconazole and is now ulcerated. So Dr. Bhari might actually help as to why that there was a thought that there's something different than what had been thought.
So, though this is an uncommon and unusual case, but this is a case which gives us an important lesson that how clinical examination or the thorough clinical examination is really important. So now once you see this presentation, subcutaneous zygomycosis, because whatever cases we have seen, we know it has a smooth appearance. Surface ulceration is not a common feature. And if we go back to the 1 year back picture, again we can see though it was almost smooth, but the lower end was showing surface erosion and surface ulceration. So we had missed it that time. But now, since he has come back with the florid ulceration, we had to re-evaluate him. So we did the repeat biopsy, repeat cultures. We were thinking of infection because of the previous histopathology. But since the previous time we could not demonstrate the organism, so this time we were hunting for a particular organism to be identified. And on DNA and molecular analysis, we could find a fungus which was suggestive of the diagnosis to be revised as mucormycosis. Though this was an immunocompetent patient, but the ulceration, necrosis, scar development, all of that was clinically fitting into it, and then it also showed in the PCR analysis. And we treated him with voriconazole, and he responded well as well.
So this one actually showed a few separate hyphens. That was a bit of a contradiction because usually with mucormycosis you see some broad separate ones, but you can sometimes have a fine ribbon-like separate as well. So I think they went a step ahead and they did the PCR for the panfungal series, which came out positive for mucorales. And then Lichthymia corambifera was actually found as the strain which was responsible. Now, is there a possibility of kind of a contamination with mucorales as well? I mean, we definitely have that one in the PCR, but again, it becomes a contaminant many a times on the skin. But here, the primary mucormycosis responded very well to voriconazole, so that probably just fits in the diagnosis and how we went into that. Now, despite no forthcoming history, would you investigate without an immune suppressive state in this child?
PCR was done from the tissue.
Workup has to be done because this is a fungus we know is common in immunosuppressed patient. So we did a routine workup, including viral marker, including the routine immunological workup, which is done free of cost in our institute. That we did, and we could not find any evidence of immunosuppression.
I think one most important clue. This is real eye opener. Extremely rare case. Immunocompetent patient, that to a child having localized mucormycosis restricted to the skin. I think there are so many odds in it, and I'm sure that it will get published in a good journal. But something which is a real eye opener is the lesion is looking like a granulomatous lesion. That's why we thought of tuberculosis, lupus vulgaris, lot of sarcoidosis. On histology, we see giant cells. But on the contrary, in the very first slide I mentioned there are epidermal changes. There is some amount of necrosis and crusting, which was very striking to my eyes. Here you see a very big ulcer. So this is a very important feature of mucormycosis because mucormycosis is an angioinvasive and thrombosis, angiothrombosis occurs, vascular thrombosis occurs. That's why the necrosis appears.
One question. You said this patient came for follow-up after a year with this ulceration. Is that correct, Dr. Neetu? But
Yes.
my understanding is mucor is a very rapidly invasive. It's one of the fungus which progresses very fast and fatal. So one odd thing I find here is for 1 year, the patient did not have much of an ulceration or necrosis. So that is something odd for a mucor case is what I
We
would like
did
to just
review
point out.
we did review of literature because this was odd. Even for the initial 3 years before the first presentation, there was no ulceration, and then it stayed well for next 9 months. But there were few reports where the variable course of progression was reported, and a presentation mimicking subcutaneous zygomycosis or rhinoentomophthalmomycosis has been reported.
That's why I added a possibility of cutaneous aspergilloma. That again, actually, it can be there for a long period of time, and again can respond to voriconazole at the same time. But again, once you've done a PCR and thing, and it's very clear that it was a mucormycosis. Now, this is the last case. It's a 10-10. Should we just continue with the last one as well?
I think we can carry on since the discussion is so intriguing.
So,
And if people are still there, quite a good number of people.
so there, yes. So this case was provided by Dr. Tarun, so he's not here. There's a 2.5-year-old female child with a history of trauma, left forearm 8 months back. So in a few weeks, the child developed a swelling which was fluctuant. So the child had already gone through 2 or 3 antibiotic courses. It was very mildly tender on examination. So I think the approach would be to definitely take the pus out and see. And the ZN staining of the pus showed AFP positive, and the PCR was positive as well for mycobacterial tuberculosis. And the impression was, at the same time, the X-rays were done. They don't have the first X-ray, but that showed a lytic lesion consistent with TB osteomyelitis and started on a standard ATT. And after the remission of lesion, maybe 7 months down the lane, there was a relapse of the lesion at the similar site, and while on ATT. And the FNAC showed AFP positivity in the staining, but the PCR was negative, and they continued the ATT. And when the child came back in about 25 days, the swelling was down by 50%. But now the plan was to look for drug resistance because the relapse after 7 to 8 months of ATT. So the first question arises, why the relapse? I mean, are we thinking about drug resistance or something else as well? Dr. Sandeepan.
I think drug resistance is, of course, a distinct possibility, but we have to rule out underlying immunosuppression. Whether the child has got primary immunodeficiency of any sort, we know there are several variants of primary immunodeficiency of different degrees. It may be a very minor, primary immunodeficiency, not having very florid other manifestations. So that has to be ruled out, or secondary immunodeficiency, whether the child has earlier received any immunosuppression or anything related to that. Even the HIV has to be done also in this sort of cases.
Absolutely. Any addition, Dr. Neetu?
Sir, I agree with Sandeepan sir. Immunodeficiency need to be ruled out. Family history of tuberculosis, if because drug resistance tuberculosis is increasingly becoming common in children because of the positive history in the family member of the similar kind of tuberculosis or in the close relatives. And if still we could not find any answer to it, then probably drug resistance need to be ruled out.
Right.
The other thing is compliance, sir. Sometimes compliance to medications also will be something which we might just miss to ask, or something we might think that the child is taking the medicines. So that is something which we always have to look for in chronic treatments like leprosy and tuberculosis.
Absolutely. And I think what happens is if there's improvement in a few months' time, actually the parents are not very, very keen sometimes, and they just reduce the dosage or maybe become intermittent. Dr. Arun, anything else you want to add?
No, we should. I mean, I don't know. I'm just seeing the X-rays here. There is an area of, especially lower end. Was there any bone tuberculosis also underlying thing, which was
There is an
not
osteomyelitis.
been completely
There was a
revealed?
lytic lesion. Yeah, there is a lytic lesion in the distal end of the
Yeah,
radius.
that's what I am thinking. Of course, a little we know, we used to call it Brody's abscess, the chronic tuberculosis of the bone.
So this
Is it
one, the
that
radiologist
which
said it's
has continued?
yeah. Sorry, carry on.
No, I have finished.
Right. So the relapse actually can be multiple reasons. Then again, do you favor kind of a DOTS therapy with the government setup, or would you actually give it if the patients are actually keen to carry on the anti-tubercular therapy with you? So is there any kind of preference over DOTS over the regular therapy that we give? Dr. Dhar?
I will go for the regular treatment.
Right.
Yeah, I don't have enough experience, so that's why I cannot, too much of confidence in the therapy, which is
Right. I think compliance probably is better if they keep with you. Drug-resistant cutaneous TB, I don't know how much in children do you see a lot, Dr. Neetu? You might be getting cases around the range.
Not a lot, sir. Very occasionally, rarely.
Yeah,
It's much more common in adult. In children, mostly we see responsive tuberculosis.
right. I think in pulmonary TB, actually in children, actually the number of cases coming are quite high as compared to what we see in extra pulmonary TB probably. But again, that has to be kept in mind, especially if you have gone through 7 months of ATT without much, with the relapse on the skin. So investigations for a drug resistance TB, they definitely go through the panel. Course of action at this point, I mean, are you going to change or do you want to carry on with the ATT, or do you want to find a reason as to why this happened? Dr. Arun?
Probably second line drugs has to be used, I believe, because having used, if there was a compliance and the drug was used properly and recurrence is there, probably we have to add the second line drugs, which all the the central, all the government agencies which run these DTCs, they usually district tuberculosis centers or the dot center would give those drugs. It is mandatory for us to report every case of tuberculosis, whether it is pulmonary, extrapulmonary, and they do these. Every district has got this testing facility for multi-drug resistant organism, and they give the drug accordingly. Here it is a clear-cut case. Probably a second-line drug has to be used. I can't comment on this more than this because we refer them to those centers.
Absolutely. So I think if it is resistant to rifampicin and isoniazid, this is a multi-drug resistant TB. And if it is beyond that, it goes to one of the fluoroquinolones and one of the injectables, they say there's extra or drug resistant. So that is XDR TBs. So this child probably would land up on a fluoroquinolone and an injectable along with the other drugs. So if the drug resistance is proven. So I think this is something which has to be kept in mind if, despite the ATT, the relapse is there. I think
One
that's
thing
where
is the second line ATT, the problem is with the cost of the medications. It becomes very expensive when we move to the second line, and injections and all complaints will be still the more worse to get patients to complete those injections. So, I mean, the ID specialists who we work with, they consider quite a bit before we shift. They try their level best to try to work with the first line as much as possible, and they move on to the second only when it is really mandatory because of other costs and difficulties in administering the medications.
Yes, I think the injectables are not the best choice for children anyhow, and it's an IM one, so it's not easy actually to give to children. I totally agree, and that's where the cases end. When somebody, would say is that doctors are investigators. So I think we are the best investigators which are there and think outside the box. So all of them actually needed some kind of an out of box thinking as to why it happened, and we do need a lot of cooperation and coordination between departments. That is the key. For example, in iron deficiency, we wanted a pediatric review. Why hemoglobin of 5.5 with the lice? It's not possible. So something else has to be there. Similarly, with the other lesions, you need pathology, microbiology, and other colleagues who can actually cast a shadow. With the lytic lesion, they need an orthopedician at the same time to look at the osteomyelitis versus Brody's abscess, as Dr. Arun said. So I thank you all for your wonderful comments and the contribution that you have made in today's evening. And I'll just pass it back to Dr. Akash. Thank you very much.
Thank
Thank
you,
you,
Ram,
sir.
for wonderful moderation.
Thank you, sir.
Thank you, sir. And it's really heartening that we have still 100 participants with us at about 10:20. So that speaks, like we have discussed, I think all infections in on and whole. So with that, I would like to just call upon the Honorary Secretary General, Dr. Maitri Panna ma'am, to give the vote of thanks.
Yeah. So thank you everyone, and my special thanks to Dr. Akash Agarwal for perfectly conducting the webinar. And also I would like to thank Dr. Tapas Kayal, our technical expert and guide of ISPD, for executing the technical aspects of this webinar. So thank you, Tapas Babu. And before we end, thank you all the delegates for attending the webinar and making it a successful session. I especially thank all the faculties for being a part of this webinar and sharing your expertise. And we as a team in ISPD pledge to contribute to constructive academics and research in the field of pediatric dermatology. So I congratulate ISPD Academy, which is led by Rahul sir and Ram sir, and the team of ISPD Academy members. They are doing a wonderful job. And I extend my heartfelt gratitude to Sandipan sir and Jaikar Thomas sir for all the guidance and support. And thank you everyone till we meet for the next webinar in around 3 months' time. Long live ISPD. Thank you.
Great. Thank you very much. Thanks a lot. Thanks,
Thank
everyone.
you. Okay,
Good night.
Thank you.
Thank you.
Thank you, sir. Thank you.
Namaste. Namaste to
Namaste.
all.
Namaste. Thank
Namaste,
you.
sir.
Thank you, everyone.
Good night.
Thanks a lot. Have a lovely evening.
Good night, sir. Good night.
Right.
Okay.
Good
Good
night.
night, everyone.
Good night.
Good night. Good night, everybody.
Thank you.
Bye bye. Good night.